This course is for you, and that's why we try and give a week to do certain things so you can customize it for you and whatever your time is. All right, so we're going to start out with that broad oral cavity. All right, so we are going to be looking at boundaries. This course is all about reading a map, and I am a lousy map reader, ladies and gentlemen, but we're reading a map. So we all need to be on the same language when we're reading this map so we know exactly what and where we're talking about. So the oral cavity begins at the lips and the cheeks, and it extends posteriorly, okay, to the back, posteriorly, to the area of the palatine tonsils, where our tonsils are. And the palatine tonsils lie on the sides of the throat between two folds of tissue. And one of the folds of tissue is in front and one is in back. And those folds of tissue are called your tonsillar pillars. So our oral cavity begins at the lips and extends to the palatine tonsils. The palatine tonsils sit between the tonsillar pillars. The oral cavity ends posterior behind the tonsillar pillars, and then the oral pharynx begins. This seems to be one of those questions that end up on boards. Where does the oral cavity end? Okay, all right, it ends at the tonsillar pillars, and after that, the oral pharynx begins. And in the area between the oral pharynx and the laryngeal pharynx, you've got that digestive system that shares a common pathway that goes with the respiratory system. So you've got to start thinking about that wonderful anatomy and physiology or your biology courses you've taken. All right, so after that, it then goes into the esophagus and the rest of the digestive system. So we've got the lips going all the way down to the digestive system. And then the respiratory system, starts at the nasal cavity, and that includes the nasal pharynx, the oral pharynx, the laryngeal pharynx, and then it continues on into the larynx, trachea, bronchi, and lungs. All right, so we're not going to be getting into all of that because our course is oral anatomy. Now your head neck anatomy, that's going to be a different course for you, okay? You're going to be concentrating on that stuff. But let's look at the oral cavity, and it's divided into two parts. You've got the vestibule and the oral cavity proper. So the vestibule is the space that exists between the lips or cheeks and the teeth. That's the space, that's the vestibule. And then you've got your oral cavity proper, and that's the area that surrounds, okay, it's surrounded by the teeth, the alveolar ridge, and back to those palatine tonsils, right? Those palatine tonsils where the pillars are the most posterior area of the oral cavity. So the oral cavity proper includes the region from the floor of the mouth underneath your tongue upward to the hard and soft palates. All of that encompasses the oral cavity. So the vestibule, remember it was between the lips, okay, and the cheeks and your teeth. So the lips are the junction between the skin of the face and the mucosa of the oral cavity. Now, skin and mucosa are two different things because they have different types of cells, all right? They have, the skin has keratinized tissue on it, and it's the outside versus the mucosa is the lining of the oral cavity. So between those two areas, there lies a transitional zone, okay, of reddish tissue, and that's known as the vermilion zone of the lip. So if you've got your book out, this is a course that it's good to have your book out so you can be looking at pictures while we're going along, because a picture is going to appear, all right? But if you can see this while I'm yakking at you, it's better. All right, so you can see that this has all of the parts that we're going to be talking about. Now, the vermilion zone is this area here. Okay, it's that zone between the mucosa. This is the mucosa, the lining, and this is the outer, the keratinized tissue here. So you've got your mucocutaneous junction. Everything's got a name to it. All right, so that's where the skin and the vermilion border meets. The commissure are the sides, the corners of the mouth. You've got your chin, your labio-mental groove. This is the mental portion of the skull, the labial mental groove. Right? The body of the lip is this whole area here, and that little area in between is the philtrum. You've got your nasolabial groove, your nasolabial groove. This is what women get filler in. And I'm too cheap to get my filler, so I got a deep groove. The tubercle is just a little elevation. So this is the tubercle of the lip, and this is called the Cupid's bow. All right, and the margin of the lips. So you can see that everything has a name to it, because if you are doing an oral cancer screening on somebody and you need to mark where a lesion is located, you need to be very specific in the language that you're using on where it is you're talking about. So the vermilion border is from this wet area here all the way down to the edge of the lip, and that edge of the lip is called the margin of the lip. Okay, the mucocutaneous junction. So the skin of the upper lip has an indentation at the midline known as the philtrum, and it's derived from the embryonic median nasal processes. You don't need to know that for my course, but guess what? You will for Mrs. Heberle's. So for my course, you just need to know that there's a philtrum and where it is. All right, so this is the philtrum. The lateral commissures are the angle, the corners of the mouth. And then you've got your vermilion border. So let's talk about some more borders. You've got your vestibular anterior border. So the anterior, anything anterior means front, anything posterior means towards the back. So vestibular anterior border are the lips or the labia. You've got your vestibular lateral borders. Lateral means the sides, and those are your cheeks, the buccal, the bucca, depending on if you're doing the Latin or the not. Okay, so you've got the lateral border, which are the cheeks, and then you've got your posterior borders, and those are the anterior border of the ramus of the mandible covered with the soft tissue. Now, you don't know what the ramus of the mandible is yet, unless you remember this from your previous courses that you've taken, but it's part of the mandible. All right, the vestibular posterior is the front part of the ramus of the mandible. So we're talking about that vestibule between the lips. All right, so you've got anterior and posterior borders. You've got the cheek that's formed to a great extent by the buccinator muscle, covered with skin on the outside and the mucous membrane on the inside. So the skin is the outside of your face, and the mucous membrane is the inside of your cheek, inside of your mouth. The buccinator muscle extends back from the corners of the mouth to join with the muscles of the upper throat wall. As it passes backward, it crosses in front of the mandibular ramus from a lateral position to a medial position. All right, so my friends, this is when I want to shoot myself. It's my eyes have glossed over and I'm going, oh my gosh, this is ridiculous. This again is oral anatomy. And for those of you, I'm using these words to kind of give you a inkling on what is going to be covered in oral anatomy, again, I'm interested more in the big picture for oral anatomy instead of head and neck. So then we've got the posterior borders. It's the, at the posterior vestibular space is the ridge of bone. That's the beginning of the anterior of the zygomatic arch. So you've got the posterior of one is meeting the anterior of another. And that's referred to as the zygomatic arch is your cheekbone. Then you've got your zygomatico-alveolar crest. So when you're looking at terms, take the word apart and see what you can figure out, because even if you don't know what the word is or where it is, if you can dissect it, it will tell you. That's the nice thing about anatomy. It will tell you. Superior, inferior borders. What is up? What is down? Superior is up, inferior is down. So the mucous membrane, or the mucosa, excuse me, of the lips and cheeks turns toward the gingival tissue. So we've got the lip and we're looking inside the mouth. So it's turning towards the gingival tissue, and that's known as the mucobuccal or mucolabial fold. So the labial is the lips, the buccal are the cheeks. So that's why there's two different terms. Are you talking about the lips or the cheek part of it? Muco is the mucosa. The mucosa line against the alveolar bone is movable and is known as alveolar mucosa. So the mucosa overlying the bone is movable and it's called alveolar mucosa. And it's generally reddish in color due to the blood vessels and the thinness of the mucosa. You can see the blood vessels. So let's talk a little bit more about the landmarks. The point at which the alveolar mucosa becomes tightly attached to the bone is the beginning of the gingiva and is known as the mucogingival junction. You are going to get to know the mucogingival junction very well. We call it the MGJ, and even in the computer, it's MG for mucogingival. You are measuring that mucogingival junction. So this is here, this one right here is the mucogingival junction. So when you take your lips and you pull them away from your mouth, you're going to see a difference in color. The mucosa, the labial or buccal mucosa, is thin and it is movable, and then it's going to attach at a certain spot, and that's that mucogingival junction, okay? Because everything from here to here is firmly bound. You can see it better down here. And this is what you'll be measuring when you're doing your periodontal assessment. You're taking your periodontal probe, which is a measuring instrument, and you're measuring to see how wide that zone of attachment is. So this is labial mucosa. Okay, this is attached gingiva. This is buccal mucosa because it's towards the cheek. So the normal color of the gingiva is pink because the mucosal layer is thicker and the blood vessels don't impart much color. The thicker the gingiva is, the paler the tissue is going to be, versus that mucosa that's loose and friable is more translucent and thinner, and it's going to appear redder. But patients with darker skin color generally have some pigmentation to the gingiva that can be evident. So this is a light-skinned person. You can see that the mucosa is just a little bit redder pink than the lighter pink of the attached gingiva. If you are a dark-skinned person or have a patient that's darker skinned, this will be can have melanin pigmentation in it, and sometimes it can be light brown, it can be splotchy, it can be almost a dark brown mahogany color as well, depending on how many melanin pigmentation cells they have. So at the midline is the center, okay? For both the upper and lower lips, there's a fold of connective tissue known as the labial frenum. Now we're inside the mouth, all right? The labial frenum, the upper frenum usually is more pronounced than the lower, and the attachment of the maxillary frenum may extend to the crest of the alveolar ridge or even over the ridge. Now, when you, depending on where the position of that maxillary frenum is, yes.
I'm sorry to interrupt. I think Ari just messaged us saying that she got kicked out of the room.
So I need to figure out, I need to invite her again. I don't know how. More. Okay, let me try this. I don't know, let me see. 30 participants in the meeting, and here we are. Admit, I found it. Thank you. Always need a moderator. I appreciate it. So we're all here again, yay. Okay, so we're talking inside the mouth now, around our lips, the midline of the lips, underneath the nose and our above our chin. We've got these frenum attachments. And depending on where the attachment is, will dictate whether or not there's going to be a space between the two front teeth on top or not, or recession on the bottom teeth on the inside, the mandibular anterior teeth. So the maxillary frenum may be so firmly attached that erupting central incisors may actually be pushed slightly aside, creating a space. It's known as a diastema. The space between number 8 and 9, the two front teeth, is called a diastema. Typically, that's the only diastema you have, but any space between any teeth is either an open contact or a diastema. People use them interchangeably. If the mandibular labial frenum extends too close to the gingiva, it can contribute to gingival recession, pulling down. All right, so this is the maxillary anterior frenum here. It's a band of tissue. We call it muscle, but it's not muscle. It's just a band of connective tissue. And you can see that it comes really close down here. That's creating the space between these two teeth. So when with children, now they're doing what they call frenectomies, where they will just take a laser and just kind of open this up to free up this frenum so it's not creating a pull. This is the mandibular anterior. The lip, every time this person moves the lip, this connective tissue is tugging, tugging, tugging. All that tugging is causing, excuse me, is causing recession. The gum line area should be right here. And you can see how much it's pulled down. And on the inside where the tongue is, the same thing can happen. So we have less defined frena or frenula, depending on what the book wants to use. And they are evident in the maxillary and mandibular canine areas, at the area labeled the mucobuccal fold, and in a similar area above on the maxillary arch. So people have generally 7 frena or frenula. You've got 1 on your upper lip, 1 on your lower lip. You have canine, you've got 4 canines, 2 upper and 2 lower. So that's 6. And then you've got 1 underneath your tongue, which is 7. So 7 is the number of frenula that most people have. And we're checking that when we're going in with our oral inspection and perio assessment, that type of thing. So there's something called the coronoid process, and that is in the posterior, towards the back, superior, upper back part of the vestibule, adjacent to the maxillary third molar area. So those are the upper wisdom teeth. And the coronoid process of the mandible can be felt when the patient opens wide. All right, so coronoid processes are landmarks. We're going to be talking about that in head and neck anatomy. You're also going to be talking about it again when you're in local anesthesia. So the second year students are having to relearn all of this landmarks, because this is going to show you and tell you where you're putting the needle and where you don't want to put the needle. So what are other clinical things that you're going to be observing is bone loss. When teeth are lost, so is the bone around the tooth. So there can be alveolar bone loss that can be visible inside the mouth with just the architecture of the mouth, or radiographically on x-rays. So then you've got your mucosa, and that mucosa is oftentimes freely movable. It contains many salivary glands, and the mucosa of the lips, cheek, and retromolar pad, retro, behind, okay, behind the molar, retromolar pads, are areas of the most common sites of misplaced sebaceous glands referred as Fordyce granules. You need to know what Fordyce granules are. They are misplaced sebaceous glands. Usually lips, cheek, retromolar pad area. And you'll be identifying those when you're doing oral inspections on each other. They appear as yellowish granular structures embedded in the mucosa. You can see them on some people you can't. So we label them when we can see them on individuals. Do we do that in private practice? Oh, for goodness sakes, no. But what we do when we're in school is we're labeling things, we're saying we can see them because we're training our eyes to look for certain things instead of just going through the motion. The buccal alveolar bone is a large portion is large. Okay, and it's on the buccal cortical plate of the mandible and maxilla, and they're bony growths sometimes, and they're called exostoses. Exostosis is the IS is singular, exostoses is plural, and exostoses are generally seen more often on the mandible than they are on the maxilla. So extra bone, okay, extra bone, exostoses on the buccal. The hard palate, we're talking about the roof of the mouth. The anterior portion of the hard palate, okay, the front portion of the hard palate, there's a transverse ridge, okay, of epithelial and connective tissue, and those are known as rugae. Now, rugae, if you put your tongue up to the roof of your mouth, those are those little wrinkles near your front teeth, and they tickle a little bit when you run your tongue along. They're covered with keratinized epithelium. That keratinized epithelium has a more of a thicker shell, so it doesn't get damaged easily. Posterior to the central incisors, okay, behind the central incisors at the midline is a bulge of tissue known as the incisive papilla. Sometimes it's a little flat, but that comes in between your two front teeth on the inside, maxillary. And beneath that papilla is an incisive foramen. A foramen is a hole. And the incisive foramen is called incisive foramen because it's right behind the incisive, okay, incisor teeth. So this foramen carries the nasopalatine nerves and blood vessels. Again, I'm not getting into that, but guess what? You're going to learn this time next year how to give an injection in that area. And it hurts, my friends. And we will all experience the joy of that on each other. All right, so this is the picture of everything that we've been talking about. So you also have a lingual to the second and third molars are 2 openings on the bone of each side. They are called the greater palatine foramina for the rest of the nerves and blood vessels of the hard tissue. Now, the nice thing is, this is your incisive papilla here. I've got a big honker of one here. So guess what this injection is called? It's called the incisive injection. Okay? This is your palatine gland here, but you've got the greater palatine foramina is right here. And that injection is called the GP for greater palatine. I used to think that it was a secret language that only people who gave injections knew about, but it's not. Now, those wrinkles of connective tissue are the palatine rugae. The lesser palatine foramen carrying nerves and blood vessels here, right? And then you've got your greater palatine foramen. So when you're doing an injection, you're going to be feeling for this little indentation here, because that's going to tell you about where you want to place your needle. So for the hard palate, the tissue beneath the palatal epithelium really varies from region to region in the palate. At the midline in the center, okay, you've got connective tissue and it's thin, and the palate feels hard and bony. Okay, that tissue is very stretched against the palate. In the anterolateral area, okay, the front sides, the connective tissue contains fat cells and is a little thicker. In the posterior lateral portion, behind and to the sides, there are numerous minor salivary glands that secrete mucus. So if your patient has their mouth open for a really long time, their mouth is dry, you're going to start seeing this tiny little drop of fluid coming out, tiny little drops, and those are those minor salivary glands. The shape and size of the hard palate vary from individual to individual, and you are going to be describing that when you do your oral inspection. Is it narrow? Does it have a high vaulted arch? Narrow, high vaulted arch, okay, those tend to be our mouth breathers, versus quite flat, okay, that has a wide jaw. That excess bone, if it's in certain areas of the mouth, we have certain names for it. So if it's in the center of the palate, it's called a palatine torus. T-O-R-U-S is singular, tori is plural. So this is a palatine torus. It is considered one. So we're not just saying this patient has a palatine torus, we need to describe it because we are into description, all right? So is it small, medium, or large? Is it smooth or is it lobular? And this is lobular, so you can see it's lobular. And you can see there's some scar tissue. This is scar tissue thickening here because this is where, as the patient's chewing and swallowing, it gets nicked a lot, okay? So it would be a torus palatinus, medium size, lobular, instead of just saying they've got a palatine torus. The junction of the hard and soft palate forms a double curving line. Everything's got a junction where something ends and something begins. You've got the posterior of something and an anterior of something else. The posterior nasal spine of the palatine bone is the primary landmark at the midline. You have 2 small depressions that are located on each side of the spine, and those are known as your fovea palatine. Your soft palate, okay, that stretches back from the hard palate. So you've got your hard palate that's firmly bound, and then you've got your soft palate, which is not. At the most posterior portion of the midline is that downward projecting muscle or connective tissue known as the uvula. Okay, that's that little flap of tissue. The soft palate movement is accomplished by the levator veli palatini muscle, which pulls the soft palate up and back until it contacts the posterior of the throat wall. You don't need to know this, okay? But all of this stuff is connected, and you'll be learning this in detail in head and neck anatomy, but it's all connected. The lateral borders, the sides of the oral cavity proper, are bounded primarily by the teeth and associated mucosa. So we're talking about the sides of the oral cavity. In the posterior lateral part of the oral cavity, so this back side part of the oral cavity, the boundary is the palatine tonsil and its associated pillar. So remember, the oral cavity starts with the lips and it ends with the palatine tonsils and the pillars. That's all it still is same, just in different language. The more prominent fold behind the tonsil, extending from the soft palate downward into the lateral pharyngeal walls, is referred to as the posterior pillar or the palatopharyngeal arch or fold. So you've got an anterior pillar and a posterior pillar because those tonsils lie in between those two pillars, okay? So the posterior pillar is also called the palatopharyngeal arch or fold. And when you have the patient open and they say, ah, this is what you're looking at. So immediately in front of the palatine tonsil is the anterior pillar. This is the anterior pillar. Or the palatoglossal arch, anterior pillar, palatoglossal arch. Then you've got your second fold here, which is the posterior pillar or the palatopharyngeal arch. And then you've got your tonsils in between. This is the uvula. Sometimes it's very pronounced. Sometimes it's not. You'll see some cultures where it's been removed. You'll see some patients where it's been removed for sleep apnea as well. So sometimes it's been reshaped and the soft palate has been reshaped for sleep apnea. You can see this little red, these little red globules here. This is just extra lymph tissue. All right, but when you're doing an oral cancer screening or oral inspection, you're having the patient open wide, you're saying, ah, and you are inspecting all of this tissue. Posterior, we're looking behind, okay? The third molars or the terminal molars, because some people don't have third molars. They were either extracted or never formed. On the bottom teeth, the mandibular arch, it's known as the retromolar pad. Retro behind, molar pad. So this is the retromolar pad. This particular picture, the patient doesn't have third molars. This is the first molar, second molar, retromolar pad. Now, when we're talking about landmarks, foramens or holes, right? You have something called a fossa also, and a fossa is a large depression, a fossa. So depressing the tongue and asking the patient to say, ah, enables the examination beyond the oral cavity into the oral pharynx, and that's the fossa. So, are we good? I know your eyes have glossed over. Big time. That's
Misty,
the mouth proper, yes.
I'm sorry. Could you go back to that one picture of the, oh my gosh, what is it called? The tonsils. That one, yeah. And then I know it points out the tonsil on the left side. Could you also point it out on the right side with your mouth?
We don't see it on the right.
Oh, okay, okay.
Yeah, because this is the anterior pillar here and the posterior pillar, so we should see something right here. Kids, when they say, ah, you're going to see these two big golf balls. They look like walnuts sticking in their throat. As we age, they atrophy, they shrink, and they get smaller most of the time, or they've had them removed. All right. Why don't we take a short break, because it's been over an hour. And I will, let's see. Okay, are we back?
Yes.
I still have 31. Okay, good, thank you. So, have I put everybody to sleep? I went downstairs to get something to drink. I'm going, oh my God, I'm putting myself to sleep. It does get better. I mean, oral anatomy is just endure this, endure it. The tongue. Okay, structures on the tongue include papilla. Okay, you need to know these papilla: filiform, fungiform, volate, and circumvallate papilla, and the roughened lateral surface of the tongue opposite the vallate papilla, which represents rudimentary foliate papilla. All right, so I'm never going to ask you about rudimentary foliate papilla, but you do need to know where the papillas are. The anatomy of the tongue. All right, so let's take a look at this. You have, this is way back. This is the base of the tongue. You're not going to see this. This is part of the throat here. Okay, from the anterior portion here, you've got your midline groove of the tongue, midline groove, okay? Sometimes it's a straight line, sometimes it looks a little crooked. Then you have something called filiform papilla, and filiform papilla makes up the bulk of the tongue, and it gives the tongue the velvety texture. Filiform. Then you have something called fungiform papilla. Fungiform papilla because they look almost like mushrooms, all right? When you look at them microscopically, they look like a little mushroom. So fungiform papilla. Then you've got your vallate or circumvallate, and you're going to see them as circumvallate more than vallate papilla. Circum just means circular. All right, and it forms a V, the circumvallate papilla here. And then you've got something on the lateral borders of the tongue called foliate papilla here, and they're little folds. So when you're doing your oral inspection, you will have to identify these landmarks for your instructor as part of the skill evaluation. And this is it's just something that you memorize, and it's very easy once you've got them, okay? So the underside or ventral, this is the dorsum of the tongue. And then if they lift their tongue up, it's the underside of the tongue. That's the ventral surface of the tongue. And that shows, it's very vascular. It shows the blood vessels because they're close to the surface. Sometimes you can even see what we call varicosities. You can see those blue veins just sticking out if you're older as well. So extending from an area near the tip of the tongue down to the floor of the mouth is a fold of tissue, all right? And that's known as your lingual frenulum or lingual frenum.
Misty?
Okay? Yeah.
We have one student that was kicked out and is in the waiting room.
No. I forgot how to get them in. Oh my. Oh, one person, I was looking at the wrong thing. Admit. Okay. We're back. Michaela, you haven't missed anything. We were talking about the tongue, okay? The dorsum of the tongue is the top portion. The ventral surface of the tongue is underneath the tongue, and you've got a mandibular, or I'm sorry, a lingual frenum that's attaching the tongue to the floor of the mouth. And you can have discrepancies in that. So when that frenum is attached too close to the tip of the tongue is going to have limited movement. And that's what we call tongue-tied. All right, ankyloglossia. Ankylo, it's attached, okay, it's anchored. Glossia, the tongue. So the tongue is anchored or tongue-tied, ankyloglossia. We're still looking at the floor of the mouth. At the base of the lingual frenum is a small elevation that's known on each side of that frenum. It's known as the sublingual caruncle. Sub, underneath, lingual, the tongue, caruncle. This is the opening for the ducts of two of the major salivary glands, the mandibular and sublingual glands. So you need to know the anatomy there. So you're going to need to know the frenum, the lingual frenum. You're going to need to know what that sublingual caruncle is. And extending from the sublingual caruncle back along the floor of the mouth on either side is a fold of tissue called the sublingual fold. Okay, so we've got somebody with their tongue sticking up here. Okay, this is the lingual frenum. You've got these two little balls, circular areas, called the sublingual, underneath the tongue, caruncle. This here is the sublingual fold. All right, so what I want you to do is to, after this lecture, when you're actually trying to absorb this information, is have a mirror in front of you and be looking at these landmarks in your own mouth. So you can identify them in your mouth, and that way you'll also be able to help your partner identify them in your mouth because you know your mouth. All right, so we've got our lingual frenum, our sublingual caruncle, our sublingual fold. This here, you can see a little vein, okay? That is like a varicosity here. You might be able to see the foliate papilla on the sides. And then we're going to be talking about plica fimbriata as well. So this is another picture, which is a little clearer. All right, there's a number of small openings of the multiple ducts of the sublingual salivary gland can be found along the sides and middle parts of the fold. So this is that sublingual fold right here. Okay, sublingual surface of the tongue, the sublingual frenum, and then this is the caruncle here. The vestibule, space between the cheeks. So this is the labial vestibule and the buccal vestibule. And just another picture of the floor of the mouth. So we've got the same structures. This is a really more pronounced caruncle, tongue up to the roof of the mouth. You've got your sublingual caruncle here, your frenum here. Okay, this is more of the frenum that broadens out. This is mandibular exostosis, and because it is located on the mandibular inside of the mouth, it is called mandibular torus. Now, torus is singular, so we would chart this as bilateral, both sides, mandibular tori. The patient has mandibular tori on both sides. The right side is smaller than the left side. So again, you would mark that larger on the left, slight on the right, moderate or medium on the left.
I have a question.
Yeah.
When do you change your vocabulary from like torus to exos, what is it?
Exostosis. Well, exostosis is anything, it's all exostosis. But if it's on the floor of the mouth, around the mandibular canines, those are mandibular tori. If it's on the hard palate in the center, that's a palatine torus. Everything else is considered exostosis.
Okay, thank you.
And it's just more of those osteoblasts just forming extra bone. It usually doesn't have any clinical bearing unless you are making removable dentures, unless you need to take impressions, unless you're trying to take radiographs. And if they've got large bilateral mandibular tori, sometimes those things are so close you can't get a sensor in between them. And the tongue is kind of sitting on top instead of the floor of the mouth. So look how small these are. Again, bilateral mandibular tori around the canine. Small, medium, or large? Kind of lobular, or are they just nice and smooth? You have the lingual frenum, sublingual frenum here. The caruncle looks a little irritated. All right, this is an older person. I can see the varicosities. Think about those purpley veins on legs. Luckily, I wear pants every day, okay? But this is what my legs look like. Underneath the tongue can look the same. The floor of the mouth is supported by the paired mylohyoid muscle, which forms a sling from the mylohyoid line on one side to the medium surface. This is more information than you need to know, but it's all connected together. The oral tissue beneath the tongue in the floor of the mouth is one of the thinnest in the oral cavity and therefore quite sensitive to trauma. That's what I want you to know about the floor of the mouth. Ouch. Okay, it gets injured a lot. And if you're nicking underneath your tongue with a Dorito or something sharp, you can end up with an aphthous ulcer or a canker sore there afterwards. It's the responsibility of all who view the intraoral anatomy, that is you, of the patient, to be aware of what the normal anatomy looks like, regardless of whether you're the dental assistant, laboratory technologist, dental hygienist, or dentist. So the more mouths you look at, the more you're going to see what's normal. You're going to see deviations from normal time and time again. And that way, when there's something that looks like it needs extra attention, you can bring it to the attention of your dentist employer. So legally, the dentist bears the primary responsibility of making the diagnosis and the treatment of the patient. But we all are looking, we are all eyes for the dentist. We as dental hygienists do an oral cancer screening, an intra-extra-oral screening. We're making the notes. The dentist is relying on us to give them the information they need when they come in, because they're only spending maybe 4 or 5 minutes with the patient. We've spent 45 minutes to an hour with the patient. We are telling the dentist what to zero in on, okay? At least those of them that are respecting our license and our education. And the more eyes, the better. The more eyes, the better. All right. This is a lot of information. It delved into more particular than what you need to know for this course for oral anatomy, but you'll be revisiting it again in head and neck anatomy. And the nice thing about our courses is there's a lot of circling around. So you're going to hear something in one course that's going to be said again in another course, and then said again possibly in another course. So it's not all new information. And that's why I was boring you all with this stuff today, okay? At least you're getting to know what some of the language is. So I'm going to stop the recording. And again, I have to figure out how to put this on Canvas.